please, you can start
Yes,
it.
sir.
Yeah,
Gaurav,
start it.
start the program.
So once again, I would like to extend a very warm greeting to all those who have joined in on Zoom and YouTube for the IMA MSN Case Presentation Clinical Series. So this is a clinical presentation series which we started off last year, having the aim that we can have fourth year subjects or final year subjects covered through an interactive clinical series session where we can have perfectly curated professors coming over and we can have the case discussion which can be helpful for both the students as well and for those who are interested in case presentation. I would like to introduce myself. I am Gaurav Jayadev. I study third year in Basaveshwar Medical College, Chitradurga, and I am the newly elected National Council member from IIMS in Karnataka. And this case presentation series is in parallel with an esteemed dignitary of judges and guests which we have. And I would like to introduce Dr. Karnaka sir, Honorable IMA Secretary, who would, sir, I would like you to state a few words and start the program with IMA prayer. Dr. Karnakar sir.
He has to unmute himself.
Just unmuted, yeah. I just did it. So thank you so much. Good evening, everybody. Again, on the behalf of IMAKSP, welcome our beloved President, Past President Dr. Madhusudan, the Chairman of the MSN and ADN, and all the dignitaries and the speakers and the honorable teacher who is going to teach us today, actually. Myself, Dr. Karnakar, Professor of Pediatric and Intensive at Rami Medical College, is the Honorary State Secretary of IMA Karnataka State Branch. I take this opportunity to start the meeting with IMA prayer. I request everybody to just listen to this. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ, ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್, IMA ಚಿರಾಯವಾಗಲಿ. Thank you everyone. I pass it back to the moderator and for further proceeding. Before that, I would like to express sincere thanks to the initiative of the new initiative for this year academics under the leadership of Dr. Srinivas, and the initiative has been well started with by the chairman of the MSN committee and also by the past president Dr. Madhusudan sir and everybody. We only wish this activity should go on regular basis so that it makes members benefited from across the state actually. I remember last year also we started very well up on time. After some time, somehow we missed more activities happening, and one of the reasons was being examination coming in the way of conducting the meetings actually. So my suggestion could be that we remember some of the activities we conducted during COVID time uninterrupted almost about 3-4 months. Similarly, the activities conducted on weekly basis, not even 1 week is missed by the Kannada Sangha, Kannada Vaidya Balagara Sangha. Every month we have crossed more than 100 meetings have been conducted without disturbance. I think that's the inspiration to say how to make this academic activity from the MSN Karnataka State Branch to go continuously. So even the exams are coming, maybe at that point of time we can leave aside the examination batch and if possibly can continue involving those who are not involved in the examination, continuing activity so that whoever is free can attend so that there is no break in the continuity of the activity. If it stops for about a few weeks, naturally, it's very difficult to restart the program. That's what we observed. So with this, I would like to express sincere thanks to you and also wish a wonderful year ahead of academic activity, good learning by the excellent teachers and also wonderful discussions by students. Thank you so much and best wishes to the team and it's back to you. Thank you so much.
Thank you so much, sir, for the IMA prayer and your kind words, and surely that would guide us forward in continuing this series as we start along. Along with Dr. Karnakar, sir, I would also like to extend a warm greetings to Dr. Srinivas, sir, President,
Yes.
the now President of IMAMS in Karnataka. So, sir, if we could have a few words from your end.
So, good evening, everyone. So, definitely it's a very pleasant situation for me to start this program. Actually, it's a wonderful program also. And anyhow, Dr. Subrata is there, Dr. Krupa is there, Dr. Mithun is there. Our so initiator Dr. Madhu is there, Madhusudan Karignur is there. And I have to express my sincere thanks to my secretary, our secretary, Honorable Secretary Dr. Karnakar. He initiated very well now, he started the program. And as he told, it is a very good program for all this one. And initially, that when we were doing PUC, we used to attend on Shankar Mata teaching program. They like that. Somehow you learn a little bit case discussions and all. And a very good teacher. Definitely, we are ready. We are definitely very good teachers, very high-end teachers only. We will ask them to discuss with you. So definitely, we will have a very good time. So I'm very, very thankful those who are very much responsible to start this beginning, these things. So thank you one and all. I wish you my bottom of my heart. I wish everyone great success and and also have to thank the faculty people here, faculty, professor, and those who came here all the way for wasting their time and to teach you. Definitely, I wish you all the best. Take care. Thank you. Sorry, I'm having some urgent with this one. I leave and you go ahead. Definitely go and take care of it. Thank you, Subrata. Take care. You are there now. So definitely you run the show, Subrata and Krupa. Krupa is there?
Yes, sir.
Yeah, ma'am. You both will take care. Okay. Thank you.
Thank you, sir. Thank you.
Okay.
Thank you so much, President Sir, for the address. Now we would like to have a few words from Dr. Shubrata ma'am, the chairman, the pillar of IMA MSN. Ma'am, if you could have a few words from your end as well before we.
Yeah, a very good evening to all of you. Having done my MBBS from Mysore Medical College and MD Psychiatry from NIMHANS, I have always cherished the clinical discussions which we have had with our great teachers. And the same thing I feel about our medical students is that we need to have a lot of clinical interaction with teachers, and with the new technology, we can sit with our IMA being the backbone, with me having a Zoom platform to do anytime, any day. I think we were privileged to do these classes, and always we have a president, secretary, academic committee chairman, and Madhusudan Karignuru sir to help us in all these things. And I just hope that our students utilize this. Whatever number is there right now, apart from that, we'll have people also looking at these discussions in YouTube link. I think that is going to be an archive for us, for the students. So thank you, Vidyadhar sir, for accepting our invite and coming here. And thank you, Anjali, for presenting today. Gaurav, you can go ahead. I'll be there.
Thank you so much, ma'am. And also a notable mention to Dr. Shantala ma'am, who is the academic committee chairman, who would also be joining us. And it's because of her that we are having the clinical sessions continued. And also Dr. Mithun M, who is an intern, who was a very strong pillar and is still continuing as to be a very vital member of the IMA MSN. So welcome you as well, sir. Then we have Dr. Madhusudan sir, Madhusudan Karignur sir, who is the IMA past president under whom the tenure started, and now he's the IMA Bylaw and Rules Committee chairman. I would like Dr. Madhusudan sir to introduce the moderator for today's session. Sir, if you could go ahead, sir.
Yeah. Good evening. Can you hear me?
Yes, sir.
Yeah.
Yes, sir.
Here is Dr. Vidyadhar Kinal. He was my teacher for both undergraduate and postgraduate graduation at Ballari Medical College. He is well-known teacher among our PG and also UG at Ballari Medical College. He has taught more than 5,000 undergraduates and more than 2,000 MS General Surgery students. And he is known for his surgical skills and teaching skills. We used to enjoy his methodology of teaching during our undergraduates. We still keep his notes and surgical chapters. Here is Dr. Vidyadhar Kinal, who is student friendly, and he will teach you about the basics about the surgical presentation of the cases. Thank you, sir. Thank you, Vidyadhar Kinal sir, for accepting our invitation on behalf of IMA Karnataka State Branch, and we shall go ahead.
Thank you so much, sir. And lastly, I would introduce Krupa ma'am as well, who is joining us, who is the newly elected state convener. So welcoming you as well, ma'am. And so, Dr. Vidyadhar sir, thank you so much for joining in. And we hope that the case presentation today goes smoothly. And we have Miss Anjali as well, who is a finalist here from BRIMS Bidar. And I would like to ask Krupa ma'am to continue from here on and introduce our guest and a presenter for today.
Thank you all for joining us in this journey of series, which is the first episode of our clinical presentation series. And as a state convener of Ima Msn, I consider this as my pleasure to welcome Ms. Anjali Gurnale, final year medical student from BRIMS Bidar, as a case presenter of the day. Welcome, Ms. Anjali.
Thank you, ma'am. Thank you.
We can start with the case presentation today.
Yes, ma'am. Firstly, good evening, everyone.
One small instruction to Anjali.
Yes, sir.
Use small sentences of English. None of us are Englishmen. And you need not be grammatically totally correct. Subject-wise, you must be correct. And there should be no stress at all while presenting. And the committing of mistakes, I don't feel that it is bad because I have 40 years of surgical experience. I think you have 4 months of surgical experience. You can't compare 40 to 4 months. And there are plenty of other doctors who are together. You will be coming out or somewhere around 100 years of surgical experience, all of them put together. You are with 4 months, anything and everything, whatever you feel like you can speak, and we will take it totally sportively. Start off now. Best of luck to you. Yes, Sanjay, start. Can you hear me?
Anjali, you can proceed with the case. We will start off now.
Please start.
Any network issues, Anjali? Shreyas, are you there?
Krupa, can you
Yes, sir.
call up Anjali?
Yes, sir. Yes, ma'am. I'm trying to contact her.
Sorry, sir, there was an issue. Hello.
Anjali, yeah, we can hear you, Anjali. Please proceed
Shall I
with the
start
case presentation.
I think she is preparing to share the screen. That's why there is a delay.
Could I share contact?
Anjali, there is a
Yes,
network
sir.
issue with.
Yes, it's on.
Anjali, your screen is visible. Make it full screen, unmute and start.
Krupa, can you call Anjali?
Yes, yes, sir.
I think there is a network issue on her side.
So, good evening. Good evening, everyone. I am presenting a case of Miss Suman Bai, a 56-year-old female homemaker hailing from Bidar, primarily educated. She belongs to class 3 of socioeconomic status. She was examined on 28th of November. The patient comes with a complaint of lump in the left breast since 4 months.
Yes.
Patient was apparently all right 4 months ago. Then she discovered a lump in left breast accidentally during bath,
Some
which was
audio problem.
painless. The growth was insidious in onset, gradually progressive in size, initially a small one, now to a large one.
Change your slide, what you are reading
No
and what
history
is
of
there on
nipple
the
retraction. Sir,
what you are reading and what you are presenting on the screen are two different, you know. See, you must be okay. Go ahead.
shall I continue, sir?
Yeah, please.
No history of nipple retraction. No history of
There is a network issue on your
no
side.
any swelling
You
in
can stop
X-ray.
screen sharing.
I'm not able to hear properly. There is a lot
We
of
can't hear you, Anjali. You just stop the screen sharing because it takes a lot of your network.
Anjali, can you do one thing?
Yes,
Can you
sir.
stop screen sharing for now? You continue presenting the case. You can screen share it with other
Okay.
device. Okay.
Okay.
You stop screen sharing for now. Meanwhile, you can connect through some other device and screen share.
Let her read. No issue.
You please start presenting the case for now.
Okay.
You switch on your
Start from
video
the
and you
beginning.
start presenting the case.
Anjali, can you hear us?
Kripa,
Yes, ma'am.
you can call her
Yes, I
later,
can.
just read out the history. You need not switch on the video at all.
Yes, yes, ma'am. Anjali, just start presenting the case, no?
No need for screen sharing.
Anjali, do you have a helper with you? Do you have a
Okay, ma'am.
helper with you by the side?
I'm reading now. Sir? Here's a patient, Miss Suman Bai, a 50-year-old female homemaker hailing from
No, the audio is not clear.
No, I can't hear anything.
No.
Anjali,
belonging to class 3
Anjali,
of socioeconomic status, coming with the
Anjali, can you
complaints
hear us?
of, shall I continue, sir?
No, we can't hear you.
Yes, sir, I can hear you.
You can hear us, we can't hear you.
Can you ask her to log into any other device?
Sir, since network issues, we will instruct
Vidya,
Anjali to join in shortly. By that time, sir, we would be grateful to know some tips from Dr. Vidyadhar Kinhal, sir, about CA breast cancer presentation.
Exactly.
Meanwhile, we'll ask Anjali to join in, sir.
Basics of examination of carcinoma breast has been, most of it, see, the breast malignancy is basically hormone dependent. Whatever you assign the reason that this is the estrogen dependent or other things, first examination should be done in open, well lighted room with she being up to the umbilicus. You must keep her just open so that the examination will be easy. But see that somebody is there with you always when you are recording history as well as the examination. Preferably, if there is a female attendant is there while examination, it is better. And all of you, whether you know their particular language or not, you must always keep a man who knows her language. What they tell you is better than what we interpret. So their answers are, when you ask them something, you must record them in their language. And always, I personally feel that do not keep the patient under stress. Already they are stressed because somebody has told them that she has malignancy. History collection should be extremely good. As all of you know that 80% of the cases in surgery, you can make a diagnosis by collecting good history. And here also, similarly, you must collect good history, correlate the history, and then try to ascertain subsequently during clinical physical examination. What I personally feel is many number of times in the examination, especially in the postgraduate examination, I have never, many times the students will not be examining the opposite breast. That is not correct. They will not be examining abdominal examination and also many number of times per rectal examination. See, many investigations have come, but none of the investigations will tell you what is the feel of a tissue. That's why I say that there are investigations which can tell you the surface of the lesion, interior of the lesion, but it can never tell you the touch of the lesion. So all investigations are there to corroborate the diagnosis that you have made clinically. Then only they will help you. Otherwise, do not ever make a diagnosis by seeing the investigations. Many number of times, boys go back to the investigations and then try to tell the diagnosis. It is not correct. You go with an open mind and examine. And always see that both the nipples are examined. What is the level of the nipple? What is the size and shape of the nipple? And then definitely while physical examination, you must always tell about the feel of the normal breast first. Never ever harp on to the abnormal breast. First feel the normal breast so that you will be able to correlate the abnormal breast consistency and other things. Whenever you enlist the physical findings, there should be history should be in chronological order, and the clinical findings that has been written in DAS you must follow: inspection, palpation, percussion, or auscultation, and special examinations for the breast. Also, I have seen boys missing the opposite side axillary lymph nodes, just examining the opposite breast and not examining the axilla. That doesn't prevent, see, there may be a lymph node in the opposite axilla, which you may miss. But what happened, these are the tips which I wanted to share with her. Somehow this comes during the flow of presentation, suddenly not during this. Otherwise, I would have prepared about 8 to 10 slides about what to do for CA breast examination, what do's and don'ts of CA breast examination. Offhand, we have to tell that at present, the clinical examination of breast is totally also dependent on the staging of the disease. They must be extremely careful about staging of the both stages, whether it's TNM staging or clinical staging. And also investigations. Investigations are really helping hand, and the usage of investigations has helped us to improve the survival rate enormously. Now we are declaring cure rate for the
Anjali is ready.
breast. Anjali is ready?
Anjali? Anjali? She called me. She is ready. Anjali.
Madhu, ಏನ್ ಮಾಡೋಣ? Shall we continue or refix the time?
Can I start the case presentation, sir?
Yeah, please.
Anjali.
Sorry for the delay, sir. There was a technical glitch. So, I'm presenting a case of Miss Suman Bai, a 56-year-old female homemaker hailing from Bidar, primarily educated, belonging to class 3 of socio-economic status, coming with the complaints of lump in left breast since 4 months.
Yes.
Patient was apparently all right. 4 months ago, then she discovered a lump in the left breast accidentally during bath, which was painless. The growth was insidious in onset, gradually progressive in size, initially a small one, now to a large one. No history of nipple retraction, no history of nipple discharge, no any swelling in axilla, no history of trauma to breast, no any such complaints in right breast. No history of fever, no history of dyspnea or chest pain, no history of pain in abdomen or abdominal distension, no history of back pain or bone pain, no history of headache or seizures, no history of loss of weight, no history of HRT, and no history of irradiation.
Okay.
Shall I continue with this?
Do you know that all no histories convey something? You have enlisted so many no histories. Is something in the back of your mind.
Yes, sir.
I think you know them. That's why you have written no history, no history. Because all of them convey something either to diagnose, either for diagnosis or for treatment. Okay, go ahead.
Yes. Past history, there is no any history of comorbidities like diabetes mellitus, tuberculosis, or asthma. No history of medical or surgical intervention, allergy, or drug intake. The personal history, the patient consumes a mixed diet, regular bowel and bladder habits, the appetite is normal, undisturbed sleep, and no history of any addictions. The patient attained menarche at 12 years of age. She had regular cycles of 3 to 4 days with adequate flow and attained menopause at 47 years of age.
Okay, how many children?
2 children, sir. She was in a non-consensuous marriage. 2 children, both full term with normal vaginal delivery. Age at first childbirth was 21 years. Both the children were adequately breastfed.
Any significance?
Yes,
if
sir.
there were to be no children, any significance for that? In nulliparity?
In nulliparity is a risk factor for carcinoma of breast, sir.
Okay, go ahead.
Family history. There's no history of breast cancer or related deaths in the family. No history of BRCA-related malignancies such as pancreatic, prostate, colorectal, or ovarian in the family.
Very good. Okay.
Shall I proceed with the general examination?
Yeah. So in a nutshell.
Yes, sir.
History has not given you much information regarding whether it is malignancy or not. Is it painful or not? The swelling is painful or no, not painful? Is the swelling symptomatic?
No, sir, it was not symptomatic.
Is there any pain in the swelling?
No, sir. It was pain.
How did she make out that she has a swelling in the breast then?
Sir, she discovered it accidentally while bathing, sir.
Okay. So on physical examination, except that she has a swelling which is painless, which may consider it as malignancy, because most of the benign lesions of the breast are painless. When you go into a lesions of the breast, there are inflammatory, there is a harmonic, benign breast diseases and malignancies. So now you have ruled out inflammatory lesions of the breast. Okay, go ahead. Yes, continue, Anjali.
Yes. General examination is conscious, cooperate. She was examined in sitting posture with both the hands on sides in adequate daylight with informed consent and a female attendant.
Okay.
The vitals were as follows: pulse rate 68 beats per minute, right radial, blood pressure 124/72 mmHg, right supine position, respiratory rate 18 breaths per minute, temperature febrile, performance status Karnofsky score 90, no pallor, icterus, clubbing, cyanosis, and edema.
Okay. Yes, go ahead.
Physical examination of the breast. The patient was
Yes.
adequately exposed up to waist and examined in sitting position with arms by side raised and on hips, also bending in forward position.
Good. Okay.
Inspection. Firstly, both the breasts were observed simultaneously. Then,
yes,
while examined, we examined the normal side first, sir.
Okay.
But there was a lump in the left breast, so left breast appears
No.
to be large as
On
compared.
inspection, what has happened to the breasts? On inspection.
On inspection, both were at the same level, sir.
What did you observe? Which one were at the same level? Both the nipples were at the same level? The level of the nipple same on both sides? I'm not. Are you hearing me? Anjali? Oh.
Nipple area.
Did you see the level of the nipples on both sides?
Complex was on the same level.
Yeah, good. Then size of the breast.
Breasts were on the same level.
Size of the breast. Both of same size?
The left one was larger compared to the right one, sir.
Left one was larger compared to the right. Okay.
Yes. There was a visible fullness in the upper outer quadrant of the left breast.
Okay.
There were no any dilated veins or ulcer, no satellite nodules or body orange, no dimpling or puckering. The nipple areola complex was intact.
Yes.
The right breast, the shape was globular, skin normal, nipple and areola was normal, no dilated veins, no puckering, ulcers or scars.
Okay.
In the axilla, there was no visible swelling. Supraclavicular and infraclavicular region, there was no swelling and no edema of arms. Movement of the shoulder joint was in full range and painless.
Okay.
Shall I continue with the palpation?
Yes. You go ahead. Go to palpation now. You have finished the inspection, which conveys a message that there is fullness in the upper and outer quadrant of the left breast.
Yes.
With no evidence of any inflammatory or neoplastic pathology causing the engorgement of the veins. Okay.
Yes.
Except left breast upper outer quadrant is showing fullness. Okay. That is the inspection point. Fine.
In palpation, the right breast had no local rise in temperature, no lump was felt, no nipple retraction or discharge, and no any cracks or ulcers. In the left breast, there was no local rise of temperature, but an ill-defined lump in the upper outer quadrant measuring 6 into 5 centimeters.
How did you examine that lump? Is there any methodology for examination of the breast lump? Any specific lump? Methodology?
Yes, sir. Palpation with the pulp of fingers, sir.
Pulp of fingers? You hold it, is it? Hollow of the palm or fingers? You use
fingers,
hollow
sir.
of the palm? Fingers. Okay. Yes?
Yes, sir.
Okay.
The lump has irregular surface, is hard in consistency and non-tender. It was fixed to skin. It moves with breast but not independent of breast.
1 minute. If fixed to skin, you could not make out during inspection?
No, sir.
Then
In
fixity is,
palpation, when the skin was pinched, the lump was, there was no separation between the skin and the lump.
is it fixed or puckered? Or tethered?
Underlying skin, sir. Puckering, that was the sunken appearance, sir.
Can you move the skin over the swelling? You're following what I'm asking? Skin moves over the swelling, or it is adherent to the swelling?
Adherent to the swelling, sir.
Achha. There is no range of mobility between the skin and the swelling. Okay, fine.
Yes,
It is
sir.
adherent
Yes,
to skin.
Yes,
Is
sir.
it more than the size of the swelling or less than the size of the adherence of the skin? Now, every
Less
question
than-
I ask you will be having some relevance while discussing the management. Okay.
Yes,
fine.
sir. It was less than the lump, sir. Less
The
than the
adherence
swelling.
is less than the size of the lump. Okay.
Yes, sir.
Then you
Then
said
it
hard in
moves-
consistency.
Yes, sir.
How did you say that it is hard in consistency? Now, what are the types of consistencies you know of?
Firm consistency, cystic, sir. And then there might be smooth.
Smooth is what is on surface. It is. So how do you make out what is soft, what is firm, and what is hard? Because what is hard for you may be firm for me. So everyone should have a guideline to say that it is hard in consistency. Is it not?
Yes, sir.
How do you say it is not firm in consistency? Okay, it is hard in consistency. How did you interpret this? Okay, I will accept your physical finding. Hard in consistency. Okay. In the last, I will be telling you all. Last, I will tell you all these things. Madhu?
Sir. Sir. Puckering, tethering. Can you throw some light on?
Yeah, definitely. If there is a PUD orange, it is definitely I will do. If there is a PUD orange, that is there is cuticular, subcuticular lymphatic obstruction. You find like an orange peel appearance on that. If it is a tethering, there is a fibrous tissue adherent between the skin and the tumor. The tumor has spread along this fibrous tissue. That is why there will be a range of mobility when there is tethering. That means that fibrous tissue which is there hanging on from the skin to the swelling, you will find a minimum range of mobility. Some range of mobility you will get. If it is fixed to the skin cannot be moved or onto on the surface of the swelling. I think I made the points clearer. PUDRN, tethering, and fixing. Okay. And one more fixing is there. She is about to.
Students kindly note. Yeah, students kindly note. These are the standard questions that examiners will be asking you in the exam.
Tethering fixity is very, very important because subsequently it will help you and bring you a good name as when you manage the malignancy of the breast. Okay. Yes. Fixity. You're telling. Anjali, you tell me. Telling something.
Anjali, you're following in, huh?
Yes, sir. Yes, sir.
Anjali, you're
Fixity
following?
to the skin, sir. Yes, sir. I'm following.
Yeah. Kindly note all. These are all very standard questions that basic MBBS students should know. And sir has raised a very good question. How do you grade consistency? Like hard, soft, smooth?
Yes.
Consistency means what? Anjali, consistency means what? It shows what I contain. Consistency word has come from, it shows what I contain. What I contain. What I contain is I contain fluid or a soft tissue, and soft tissue under deep pressure, that is hard in consistency, or it can also be woody hard or stony hard. That also I will describe later. Okay. Yes, go ahead. Anjali, don't worry, you're doing well. Good.
Anjali. Yeah, reciprocate always. When sir tells something, just speak yes or no, something.
Hey, she is doing good. I'm happy that Bidar is my place where I have started my education. And there is a girl presenting from that medical college. I'm so happy. Go ahead, Anjali.
Yes, sir. The lump was fixed to the skin. It moves with the breast, but not independent of breast.
Okay.
It was not fixed to the chest wall or pectoralis major muscle, and the nipple areola complex was intact.
Is it underneath the nipple areola? Any part of it is underneath the nipple areola? A
No,
portion
sir.
of lower
It
border?
was in the upper outer quadrant, sir.
That's what I'm telling you. Lower border
Yes.
is near the nipple areola or no?
No, sir.
Subsequently, it will help you because EBC and ABC, nipple areola complex, play a big role in managing. Okay. It is fixed to pectoralis major or not fixed to pectoralis?
No, sir. It was not fixed.
How did you interpret this? How did you conclude that it is not fixed to pectoralis major? You following my question, Anjali?
Sir,
How did you? Hello?
the muscle pectoralis major.
Hello?
Yes, sir.
How did you interpret that it is not fixed to pectoralis major?
Which test you do? Can you hear us?
How can you make out a lump is getting fixed to any muscle? Forget about pectoralis. You can take brachioradialis or coronata arteries or biceps. There is a swelling there. It is adherent to that muscle or not? How will you make out? Madhu Papa ಅವ್ರದ್ದು ಇದು ಇಲ್ಲೋ
Network issue, Anjali.
network issue. A lot of network issue.
Of the
She is
pectoralis
trying
major
to.
muscle. Sir, by moving the fibers of the muscle, sir.
How can you observe fibers of muscle in front of the back? There is breast in front.
Vertically along the fibers of the pectoralis major muscle.
When you contract a pectoralis major muscle in a female, will you be able to see that?
Yes, sir. The patient was asked to keep the hands on the waist, and
Okay.
the pectoralis major muscle was taut. As the fibers of the muscle passed vertically, and when the lump was moved along the fibers, it was.
Where is pectoralis major inserted? Where is pectoralis major inserted?
Mobile, sir.
Huh?
It runs vertically upwards, lateral intertubercular circus of the humerus, sir.
Lady between two majors. Okay. Okay, you are right. It gets inserted to the. Is it an
Intertubercular
adductor
circus
or
of humerus, sir.
non-adductor? Is it adductor of the shoulder joint? No, adductor.
Yes,
Okay,
sir.
forget about
adducts,
it.
sir.
How did you conclude that it is not adherent to pectoralis major?
Sir, it was mobile, sir. When we tried to move in its contracted state.
I'll tell you. Please remember
was
this. All the
mobile.
sentences. Please remember this. All the sentences are important. Not only for any lump in the breast, for lump anywhere. Whenever you hold a lump, range of mobility of that lump should be noted in two perpendicular directions. Number one. Remember this. Whenever it is, wherever the lump is there, you hold a lump and study the range of mobility, ROM. Range of mobility of the lump should be examined, noted in two perpendicular directions, maybe upward, down, and lateral. It depends upon the way the stone, the lump is existing. And after that, you contract the muscle, which it is in vicinity. If the ROM of that swelling has come down in one of the directions, it shows that I am adherent to him. It shows that that lump is adherent to the muscles of my muscle fibers by this lump. I think I am making it very, very clear. Now you start imagining yourself as holding the breast. Okay, holding now. Then hold that lump, move in two directions, note down the range of mobility, then ask her to contract pectoralis major. Again, do the same movements. If the range of mobility remains on both sides same before and after contraction, that means that swelling is not adherent to pectoralis major. Fine? Okay, good.
This is one of the very basic questions that will be asked to undergraduates. Kindly make note of all these things.
Go
Anjali,
ahead.
can you hear us? Anjali?
Problem is over. Anjali, you are from Maharashtra or Karnataka? Anjali?
Can you hear us?
Sir, from Karnataka.
Karnataka. ಯಾವ ಊರಮ್ಮ ನಿಮ್ಮದು?
Sir, Bidar, sir.
ಬೀದರೇನಾ? ಎಲ್ಲಿದೆ ಬೀದರ್ನ ಮನೆ?
Sir, Devi Colony, sir.
ದೇವಿ ಕಾಲನಿನಾ? ಓಕೆ, ಡೋಂಟ್ ವರಿ. ಇದನ್ನ ಯಾಕೆ ಪ್ರಶ್ನೆ ಕೇಳಿದೆ ಗೊತ್ತಾ? ಯು ಆರ್ ಗೆಟಿಂಗ್ ಟೆನ್ಸ್ಡ್ ಅಪ್ unnecessary. There is no need. What I am telling is 40 years knowledge. What you are telling is 4 months knowledge. We are proud of you. You are able to use so many medical terminologies at such an young age. Surgical terminology. Very good it is. Go ahead. It is not adherent to pectoralis major. Fine. Next.
Anjali, can you hear us?
There is a network issue on her side.
Yes. The regional lymph nodes, sir.
Yeah, Heli, Anjali. I think you have to change your position or place. There is a network issue there. Anjali?
The regional lymph nodes, sir. Am I audible, sir?
You are audible,
Irregular.
but alternate sentences are audible. Because you have already proceeded to the regional lymph nodes. Okay, there is a lump in the breast
Yes.
which is adherent to the skin, not adherent to the posteriorly, not adherent to the pectoralis major. The mobility of the muscle, I mean, the lump occurs in both directions, but it is fixed to the skin. The skin fixity is less than the size of the tumor. Okay, that's what I
Yes,
think.
sir.
Yeah, tell me what
Yes,
about the lymph nodes in the axilla?
The regional lymph nodes, sir. Both the axillae are normal. No lymph nodes are palpable.
नहीं,
in
ऐसा तो नहीं
either.
चलेगा, ऐसा तो नहीं चलेगा. No, your regional lymph nodes, you have to enlist what are the regional lymph nodes you have examined and how you have examined.
Yes, sir. The axillary lymph nodes, the axillary group of lymph nodes, which includes 5 groups. The pectoral group, brachial group, the subscapular group, the apical group, and the central group, sir.
Since it is an education what you are taking up, whether it is enlarged or not, how do you examine each group?
Yes, sir. The pectoral group, sir, it is situated behind the anterior axillary fold.
Okay.
So, firstly, the patient's arm is elevated and using the right hand for the left side, the fingers are palpated behind the pectoralis major muscle.
Okay. Why should her hand should rest on your hand? Why the patient's hand should rest on your other hand? What is the motto behind this? Anterior axillary fold comprises of what? It is formed by what?
Sir, that will relax the pectoralis minor.
Yes, very good. Whenever you try to examine any lump anywhere, the intervening muscle should not be contracting. It should be relaxed so that you can feel the structure easily. Okay, fine.
With the pulp of the fingers, it is palpated, the lymph nodes are palpated, sir.
Okay.
And again, the thumb of the same hand is used to push the pectoralis major backwards.
First major backwards. How did you do it? Anteriorly you push. Okay. Fine.
Anteriorly, sir. Then the brachial group, sir, it lies in the lateral wall of axilla.
Where does the axillary tail of breast drains?
Spencer, in the axilla, sir. From the
Okay, so all
foramen
5
of
groups of
Langer.
lymph nodes are not enlarged. Okay, you
No,
will
sir, they are
accept your
not
physical
enlarged.
findings. You will accept your physical findings. Okay, Then the other group also, anything you have examined in the supraclavicular region?
Yes, sir. The lymph nodes, the cervical lymph nodes, sir.
Okay, you did not find anything. Opposite axilla is also normal. Isn't
Yes,
it?
sir.
That's what you wanted to say. Anything else?
Yes.
Any other positive findings you would like to enlist?
No, sir. Even the systemic examination, everything was found out to be normal.
Okay.
Like the CVS normal heart rate and rhythm, S1 and S2 sounds were heard. In the respiratory, normal vesicular breath sounds. On CNS, no neurological deficit. Per abdomen, no organomegaly. There was no tenderness of spine.
So skeletal survey you must always do. Skeletal survey. Because the malignancies can go and deposit themselves in any of the flat bones or not long bones. Okay, go ahead. What's your provisional diagnosis?
A 56-year-old postmenopausal woman with a painless lump in the upper outer quadrant of the left breast. There were no skin changes or chest wall involvement. It was not associated.
No, there are skin changes. It is adherent to skin.
It was adherent to skin.
And then you said no changes. Okay. Yes.
It was not associated with lymphadenopathy. It is most likely to be a case of carcinoma of breast, stage 2B, T3NOMO.
What are the points in favor of malignancy?
So firstly, coming to the age factor, sir.
Good.
Postmenopausal woman.
Good.
And about the 4th and 5th decade of life.
Okay.
Then a progressively enlarging mass.
Short history. Okay.
Adherent to the skin, sir.
Consistency.
Hard consistency, sir.
Hard inconsistency. Many number of times conveys that it is malignancy. Then adherence to skin. It is malignancy. Okay. So stage you already described. Okay, I will accept. Any differential diagnosis you would like to propose?
Sir, I would say traumatic fat necrosis, but there was no history of trauma, sir.
Never ever commit that if there is a res ipsa locator, there is no need to enlist differential diagnosis. What is res ipsa locator?
Negative history, sir.
Res ipsa locator. Okay, complete your examination. One of our colleague is requesting us to allow her to complete the examinations. So please go ahead. Complete your presentation so that the questionnaires will start last. All of them can put their questionnaires on the chat box. Okay, go ahead, Anjali.
Yes, sir. The provisional diagnosis, investigations, we could go for fine needle aspiration cytology, a true cut biopsy, CECT chest, abdomen, pelvis, bone scan for metastasis.
Okay, you're listing the investigations available. That's what it looks like. The first investigation that you would like to do is?
FNAC, sir, fine needle aspiration cytology.
What I want to know is whether it is, okay. Would you like to do a mammography?
So mammography is a screening test.
The mammography is described into two parts now. One is when in this thing you have to take mammography.
Screening and diagnostic, sir.
Yeah, the screening test is also there, but diagnostic, not diagnostic. For diagnosis, it will definitely give you some information. Sometimes there are multiple focal lesions. How will you make it? Clinically, you are able to palpate only one lump. But if there is a mammography, you will be able to make out that. Okay, you do an FNAC. What do you want to see in FNAC? And which needle gauge you use? Yeah, all of you are allowed to ask questions on chatter box. Let me make this clearer. One of them are asking that can we take up the questions at the end of the presentation? Definitely we can take up the questions. No problem at all. Okay. So you have done an FNAC.
A 23 gauge needle is used for FNAC, sir.
Okay.
We
What
can
is
assess the
FN?
cytology.
What is FNNAC?
Find non-needle aspiration cytology, sir. For
Why
the
do you,
superficial lesion, sir. It is done for the superficial lesion
the
of the
cytological morphology is not lost. If in FNAC, the cytological morphology or membrane gets affected because you are sucking it. In FNAC, as it is, it comes out. If when in doubt, they try to do an FNAC, but it has not picked up so much popularity in the market. Okay, then what
Then,
else?
sir, usually the investigation of choice is a true cut biopsy, sir.
That is good. Why?
Sir, because it is a biopsy, so we get the tissue status also, sir. In FNAC, we had only the cell status, the
Fantastic,
cytology.
very good. Why do you want the tissue, not cells?
Tissue, if it is in situ or invasive, sir, like carcinoma.
No. How does it help you later?
Tissue metastasis.
You have taken a tissue,
So
chunk of
the
tissue.
the receptor status, sir, the cell ER/PR positive.
Then
If it is an in situ or invasive carcinoma.
Immunohistochemistry.
Yeah, immunohistochemistry. The receptor positivity.
Under that you can write down all those things. So if there is a tissue immunohistochemistry, then you will be able to see after doing anything that you are tackling the lump, any methodology you would like to. Subsequently, no tissue is available to compare the immunohistochemistry. Now you can come to how will you plan now? You agree that it is a malignancy. It is arising from duct, not from gland, okay, not from globules. Fine. The stage, I have agreed with your staging that you have done because the skin tethering is not beyond the size of the tumor. I have agreed to your this thing, staging. Okay. What do you want to do?
So the workup includes surgery, chemotherapy, radiotherapy, and hormonal replacement therapy options, sir.
That is for writing a theory answer. There is a patient sitting in front of you. What do you want to do her? What is your plan for her?
Sir, I would go for surgery, sir.
You would like to do surgery first. So what are all the guidelines for doing surgery first or any other guideline that has come now? ABC and EBC. What do you stage this tumor as? Advanced breast carcinoma or early breast carcinoma?
Early breast carcinoma, sir.
Early breast carcinoma. Early breast carcinoma, first line of choice is what? If it is an early breast carcinoma, you would like to do surgery first or anything else first? No, go ahead. No, you would like to do surgery. That's what you want. See, the present, what is going on in the market, carcinoma breast management in all the countries is that as far as possible, save the breast. Now you tell me what you want to do.
Breast conservation surgery, sir.
Would you like to do surgery or anything else?
Chemotherapy, sir.
It is called as what?
Neoadjuvant chemotherapy.
Yeah, come out with that. Recently, I had a problem. One of VIP's daughter had malignancy. We did neoadjuvant chemotherapy. Please believe me, not even a small iota of 1 millimeter swelling was there subsequently. So how will you plan unless you have a core needle biopsy? Okay, neoadjuvant chemotherapy. What do you want to give?
Sir, there are regimens. We have CAF regimen and CMF regimen, sir.
Okay. So whenever you tell, what is posology? Do you know anything about posology? Have you heard this word? Have you heard this word, Anjali? नहीं हो तो जल्दी बोल दो हम आंसर
No,
दे
sir. No, sir.
No, better it is so that you are giving option for posology means drug dosage duration. That is posology. 3 days. You name the drug, you name the dosage and also duration. So in this, what will you do? At what intervals you would like to give? Since you are a final year student, it doesn't matter. So chemotherapy or neoadjuvant chemotherapy is a good answer. You already passed in that, scored good marks. So what will you do now? You have given neoadjuvant chemotherapy. The swelling is subsequently reduced, so substantially reduced in size. What surgery you would like to do? Name the surgery.
So modified radical mastectomy, sir.
Arey, nahi yaar, nahi yaar. Oh, mastectomy means you have to take out the whole breast, is it? I have already told you that breast conservation surgery is the fashion of the day.
Yes, sir.
Then modified radical पूरा निकाल देंगे क्या? नहीं. So what do you want to do now? That's after
Breast.
giving neoadjuvant chemotherapy, the size of the tumor has come down substantially. What would you like to do?
A breast conservation surgery, sir.
What is the breast conservation surgery? Anything details about one or two names of breast conservation surgery you know?
Lumpectomy, sir.
Very good. Then
Quadrantectomy.
very good.
Partial mastectomy. Segmental mastectomy.
Segmental mastectomy. Partial mastectomy is not a term in vogue. However, I accept segmental or quadrantectomy or only lumpectomy will do. And then what will you do for that lump? You have taken out the lump. What should you do? You will send the lump for you excise the tumor ready. Where will you send
Yes.
it to? You are not asking, you are not understanding the question. You have taken out the tumor, it is in your kidney tray on the operation theatre table. What will you do for the tumor? Most important part of any histopathology, you have to send it for histopathology, specifically writing the margins of the tumor, positive or negative. The margins of the tumor are extremely important and pathological evaluation because the type of the tissue that is there in the lump that you have sent always helps us to assess the prognosis of the disease. What are the types of malignancies you know of, histopathological malignancies?
So
Best? Yes, good. Yes, good. As a final year student, you must know that it should be sent to histopathology, and histopathologist, you request them to assess, comment on the margins of the lump. Are they tumor free? The lump is tumor free. Are you able to hear me, Anjali? Hello? Others are able to hear me? One message I would like to give to all the colleagues that are there with me and students with me, that treatment of malignancy is achieve the maximum cell kill with minimum intervention. That is the main motto. Maximum cell kill for a malignancy, you must achieve the maximum cell kill with minimum intervention. So what has happened is the volume of the malignant cells are reduced by giving a neoadjuvant chemotherapy. Because many a times we tackle locally, but already some cells have passed through the stream of blood flow or venous flow. So whenever you give a neoadjuvant chemotherapy, small soldiers here and there spread all over the body will die of because of neoadjuvant chemotherapy, and the major captain that is there in the breast it will become a smaller one. So this has achieved both the local cell kill as well as general cell kill when you do an neoadjuvant chemotherapy. The next fastest and shortest duration cell kill is achieved by surgery. Wherever you go, whatever malignancy you tackle, whether it is malignancy of colon or colonic malignancy or any other malignancy you are tackling, the surgery is one thing with the shortest duration. It gives you the maximum cell kill or maximum separation of the malignant cells at such a short duration. So the brunt that falls on the health system is definitely suddenly the patient starts improving because the malignant cells have come down substantially with whatever methodology you're trying. Now we have done a neoadjuvant chemotherapy. You have planned for a surgery, whether it is depending upon the status and stage of the disease and response of the disease. Because after third dose, if it doesn't respond, there's no question of waiting. You have to do surgery. And then depending upon the decrease in the size of the tumor or increase in the, you have to plan your surgery. Subsequently, after getting the report from the histopathology, the margins free or margins not free. If at all margins are not free, that means you have to go for a completion mastectomy, because if the margins are still affected, then they can't save that breast anymore. And other thing is you have to have a radiotherapy that is called as teletherapy and brachytherapy. What is teletherapy and what is brachytherapy, Anjali? So you have to plan for a teletherapy and brachytherapy. And first of all, one thing we must remember that all problems of breast are dependent on hormones. Estrogen is the culprit which produces the malignancy in breast. So now we have to tackle, after giving chemotherapy of same of regime you have described, now we have to tackle the reduction of the estrogen dose in the body. So you call anti-estrogens, or what others? Any idea? I don't know whether she's online or. Anti-estrogens such as tamoxifen citrate. Then you have done immunohistochemistry, you'll be able to find out that monoclonal antibodies also can tackle, such as trastuzumab or leptinum. And you also can tackle, yes, madam. Madhu? So estrogen reduction.
We've lost connection with her, sir.
Estrogen reduction, estrogen blocking, estrogen conversion, such related drugs are to be used, and also vasculature development factors are there. They also prevent spreading of the disease or recurrence of the disease. Radiotherapy, chemotherapy, hormonal therapy, immunotherapy, and last but not the least, most important is counseling. Counseling is the one thing which makes, because if there is a depression, it has been proved beyond doubt that serotonin and dopamine levels which increase during these things will enhance the speed of spread of the disease. So we must be able to convince them that what is the disease, how can you tackle, and they should be at the right status. Then the spread of the disease can be controlled. Many number of diseases, not only CA breast. That's what I wanted. Aromatase inhibitors. I wanted the answer from her. I didn't. I don't know whether she is online or not.
Yes, sir. The aromatase inhibitors, aminoglutathione, arimidex, letrozole.
Okay. Aromatase inhibitors does what?
So they prevent the peripheral conversion of estrogen, sir.
Yes, it comes in the way. And if you just analyze that, in a matter of 1 week, the 98% production of estrogen is prevented by these aromatase inhibitors. Tamoxifen is an anti-estrogen. It sits on the receptors where the estrogen won't sit, so that there will be selective separation of estrogen, trying to increase the incidence of malignancy or increase the number of cells for malignancy. Yes. What is the survival rate of stage 1 disease? You have done all these things which have been enlisted, such as neoadjuvant chemotherapy, radiotherapy, and surgery. And what is the stage 1 disease has got survival rate? A stage 1 disease with 55-year-old lady, what is the survival rate?
90%, sir.
So 90% what?
5 years survival, sir.
5 years survival rate. It is 98% with the stage 1A up to stage 1B. But however, all these combined full-pronged attack, you will be able to get 98% 5 years survival rate. And one thing very important is, depends upon the histopathological type which you have got, because if the pathology is multicentric or multifocal, the possibility of same type of malignancy can occur in the opposite breast. What is the incidence of opposite breast malignancies traced over a period of 10 years? What is the incidence of malignancy traced over a period of 10 years? All participants can ask their questions in the chat box now. I can answer questions. Please write down your questions. There are 62 participants at present. Anybody else would like to ask something? Anjali, you only ask something which you want to get the clarification. If I know, I will answer you.
Sir, the previous question only I wanted to know the answer, sir.
What is
The
that?
incidence of carcinoma in the opposite breast.
That's what you must know the histopathological lesion, then you'll be able to answer that. What are the two types of histopathological lesions you may get in the breast? Atrophic sclerosis you will not get. Trace over a period of 10 years, 55 years, 50 years and above, there is incidence of malignancy on opposite in 0.2%. 0.2%. If you operate at 200, you will get 2 cases. Okay, 0.2%. That is the study
Okay.
evidence. Okay, then. Breast reconstruction you don't want to do, you have done a radical mastectomy. In between you're answering modified radical mastectomy.
Yes, sir.
What are the other mastectomies you know of? What are the other mastectomies? Your simple mastectomy, you said, radical mastectomy, modified radical mastectomy, anything. What is the rotor's lymph node?
The lymph node between the pectoralis major and minor,
Yes.
sir.
So, you must know this because you have to clear that during surgery. Okay. So, you have taken out so much of breast tissue, everything, and the whole anterior chest wall is now vacant with no this thing. How will you cover that? Any plastic surgeon helps you?
Yes, sir. We can
What
use
would like?
reconstruction flaps, sir.
From?
DIEP flaps and TRAM flaps, sir. DIEP is the deep inferior epigastric artery.
Okay, good. Then?
And TRAM is the transverse rectus abdominis mucocutaneous flap, sir.
During surgery, when you're trying to do modified radical mastectomy, what are the structures which you must be careful of while doing surgery?
Yes, sir. There could be injury to the intercostobrachial nerve, sir.
Okay.
To the thoracodorsal nerves.
Okay. You have a scapula that is winging.
Winging of the scapula, serratus anterior, sir. Long thoracic nerve.
Long thoracic nerve. Then you are now towards only nerves you have concentrated. You cannot be partial. You must
The
also say about the main.
thoracodorsal pedicel.
3 nerves you have completed.
Axillary veins.
Then?
Axillary vein.
ಮತ್ತೆ ಕೇಳಿಸೋದಿಲ್ಲಮ್ಮ. There's a lot of problem. There is no internet in Bidar. Axillary vein.
Sir, axillary vein, sir. Axillary vein. Long thoracic nerve. Lateral and medial pectoral nerve, sir.
And lateral medial pectoral nerve. What do they do? No.
Muscles,
no lateral and medial pectoral
and the thoracodorsal pedicel.
You already taken out the whole pectoralis major muscle. Where is the question of lateral and medial pectoral nerve? No. So long thoracic nerve, thoracodorsal nerve, intercostobrachial second, and then axillary vein. Okay, go ahead. So you have done a reconstruction. What is your instruction to the patient while sending home? Important instruction that you have to tell the patient before sending home.
Follow up, sir.
She has developed malignancy of one breast. Tell me what instructions you are giving her. Internal mammary chain is draining breast or not? Internal
Yes,
memory
sir.
chain of lymph nodes is there. Now you tell me what is the instructions you send her when you send her home.
Yes, sir.
Retroexternally, do you think the internal memory chains
Regular
are linked
follow-ups.
in between?
Yes, sir.
Regular follow-up of what? He coming to you is okay.
Okay.
Concurrently, no, there is internal memory chain. I don't think we have tackled that. Only during radiotherapy and chemotherapy we have tackled. Surgically, we have not tackled. So what do you observe for the, you send her with some instruction to the house. You have to do this. What is the usual instruction to every lady is given after 30 years of age? That while taking bath?
Yes, self-examination, sir.
She must concentrate more on her left remaining breast.
Left breast.
Almost every week she should continuously examine her breast, because chances of opposite breast getting the malignancy due to this malignancy are very much on the higher when compared to the normal individuals, other individuals. So you must give her an instruction that she should thoroughly examine her remaining breast, whether it is left or right, and then she should, when in doubt, she should reach the physician surgeon as early as possible. Okay. Any other doubts you have? I'm very happy
Yes.
that you have presented your case very nicely in spite of internet not cooperating with you. However, your presentation has been very good, and you have structured and you have studied well for the CA breast, and undergraduate students finally are so much of knowledge about plastic surgery and chemotherapy, radiotherapy, and so many surgeries that you know of. Probably you have seen all those surgeries which are enlisted now. Lumpectomy or modified all that you have seen?
Sir, I've seen lumpectomy, sir.
No radical mastectomy, you have not seen.
No, sir.
Can I have the freedom of asking the name of your HOD of surgery in Bidar?
Shivyogi Bali, sir. Dr. Shivyogi Bali.
Okay. Just you pass on my respects to him, because he has prepared a very good student and you have very bright future. Anybody else would like to ask questions? Please ask.
I would like to thank for your patience, sir, because there were so many technical glitches, and also
knowledge wise you
it
are
was a good learning
for an
experience for
undergraduate
me.
students, knowledge wise you are
committee.
Thank you.
Krupa?
Hello, sir.
Krupa, idira?
Sir, I had actually one question.
Yeah, please.
So it was asked by one of our local examiner during our end posting test, that is explain about ghost approach in breast surgery.
What is that?
Ghost approach, ghost, Ghost, ghost approach.
It is best way of answering in medical examination is when you don't know, you say I don't know. So that next question will come to you. However, till yesterday I was reading CA breast, I did not get this word at all.
Yes, sir. Even I searched in textbooks, but this was the last question which sir has asked me actually, sir.
Probably
Ghost
he has
approach.
been, neoadjuvant chemotherapy, some people say ghost surgery because it totally disappears. No surgery has been done, but still it disappears.
Okay, sir. Okay.
Let me take the name of present MLA here, whose daughter was operated by me, not operated by me, chemotherapy given, and she refused subsequent surgery. Okay, no problem.
Okay.
So ghost surgery, I can only interpret like this, but it is not a definite answer because there is no evidence to suggest that in the literature which I have read.
Okay, sir. Thank you, sir.
Thank you, everybody. It was nice. I have enjoyed the whole session. Some internet problem has been not by ours, but somebody else. The facility available at Bidar may not be up to the mark which we expected, but however, her performance has been extremely good. Congratulate and say good to Anjali. Very
Thank
nice.
you, sir. Thank you so much, sir.
Hello, Doctor. President-elect Chinivalar is there.
ವಿದ್ಯಾಧರ್
Sir, namaskara. Sir, namaskara.
ನಮಸ್ಕಾರ ಈ
ನಮಸ್ಕಾರ.
ಸಿ ಎ ಬ್ರೆಸ್ಟ್ ಒಂದ್ ಕಡೆ ಆದ ನಂತರ ವೆದರ್ ದಿ ಸೇಮ್ ಪೇಷಂಟ್ ವಿಲ್ ಹ್ಯಾವ್ ಎನದರ್ CA.
Another CA means some other organ CA.
Some other organ CA.
Ovarian carcinoma.
Ovarian, apart from that one of my close relation, she had CA breast, left breast in the year 1988.
Chinivalar, sir.
Yes, sir.
Sir, is undergraduate, sir. Undergraduate class
ಆಮೇಲೆ
PhD MCH questions ಹೆಂಗ ಪಾಪ ಅವ್ರಿಗೆ.
Structures which are related to estrogen can develop malignancies.
That
is
lady,
the usual interpretation.
yes, that my close relative survived for 30 years. That I wanted to say.
One of my relatives is there. I operated in 1980. Still, she's surviving. She's refusing to die.
Okay,
Okay,
sir.
so nice, sir.
Yes, very nice. Actually, refreshing us also.
Krupa, are you there?
Sir, I would be continuing on behalf of Krupa ma'am.
Yeah, Gaurav?
Yes, sir.
Yes,
Yeah,
sir.
you are
Yes.
there, no? Yeah,
Yes,
So
sir.
Gaurav will give the vote of thanks.
Yeah.
Thank you so much, sir. It has been a wonderful
Gaurav?
session.
Gaurav?
Yes, sir. Sir, am I audible now?
1 minute. Yeah, 1 minute. Am I audible?
Yes, sir.
Yeah. On behalf of IMA KSB, I thank Dr. Vidyadhar Kinal, who was known for his teaching skills. And don't get carried away by high-end investigations, as told by Professor. We need to stick to it, clinical examination part and basic investigation. And basic questions in between what Sir has asked, they are the standard questions. And if you answer all those things, take it from me, you are passed. Over and above that, those questions will carry the more marks and you can get into the medals or distinction. Okay, over to Gaurav. On behalf of
Gaurav will give the
all
vote
the
of thanks.
students and
On
especially
behalf of
Anjali,
Vidyadhar Kinal, thanks IMA for having given me an opportunity to take part in the CME. Any more such chances, I am here always. My services are always there for IMA case. Okay.
Thank you, sir. Thank you, sir. Apart from technical issues, it was a very good discussion. I thank all. Gaurav, over to you.
Thank you so much, sir. Again, extending a warm thanks to Dr. Vidyadhar, sir, for his vast experience and his wealth of knowledge, for which we can carry forward the confidence into presenting clinical cases, and to Miss Anjali ma'am as well, who, despite the technical difficulties and glitches, we could conduct this clinical presentation. The same would be uploaded on YouTube as well and would be shared among college groups. So hopefully that would enlighten all the students who missed out due to exams, other reasons. And to begin with the vote of thanks, again, I would like to thank Dr. Karnakar sir, IMA Secretary, Dr. Srinivas sir, the President of IMA Msn Karnataka, Dr. K. Shubrata ma'am, the Chairman of IMA Msn Karnataka, Dr. Shantana, who couldn't join us today, the Academic Committee Chairman, and Dr. Madhusudan sir, who has worked extensively as IMA past President and the Bylaw and Rules Committee Chairman, and Krupa ma'am, who is the current IMA State Convener, and Dr. Mithun sir, who is the State Coordinator, and myself, Gaurav Jaydev, the National Council Member, would like to extend a warm thank you to one and all who joined us here. And hopefully we can have your feedbacks and more of these sessions will come forward and in a more better way. So we're looking forward to it. Thank you so much, everyone.